I have some disclosures, but this talk is about failed Latarjet. So this is a challenging group of patients. There's not so much in the literature out there, so it's often for the surgeon from case to case. And we know that if the Latarjet primarily is challenging, the revision is even worse. And either it's been arthroscopically or open surgery before. We all know that coming into this scar tissue and being a little bit afraid of damaging the nerves might be, well, getting us nervous from time to time. At least it should. So I think that when we have these patients with a failed Latarjet, we have to first outline the reason for failure. And I think in these cases that the CT scan is mandatory, so we can do a proper evaluation of both the position of the bone block, as we saw very nicely in the last presentation, and also osteolysis of the bone block. And in some cases I've seen large cysts in the glenoid that might do it more difficult to do fixation of another bone block. And we also have to remember that because these are challenging cases and maybe sometimes the first surgery was done on the wrong indication, we also have to consider if this patient can be treated without surgery. And also, of course, for some selected patients, even if they had a bony procedure before, this might be done on a wrong indication. Maybe it was a hyperlax patient without bone loss. So soft tissue procedures is also a possibility in selected cases, even though they had a Latarjet or a bone block before. So some thing we have to consider is the previous graft is suitable for the revision, so we can do a fixation of the same graft again. This was one of our first patients when I started to do the Latarjet arthroscopically. He was active in longboard, so he had several dislocations when he followed the longboard. And first he had a Bankart that failed after 1 year, and he came back and we did the arthroscopic Latarjet, but he did not exactly listen to me. So he did longboard after 6 weeks after the surgery, and of course fell on his shoulder again. So the screws broke like this, and we did the CT scan, and it showed us that the graft was okay, it was not fractured. So the two screw heads and the broken screws were still in the graft. So we were able to do a revision. We did it with open surgery then. And we were, of course, not able to remove the screws inside the glenoid, but we just used the same graft and did a refixation with new screws. But it's not always like that. We have to consider if we want a sling effect for the second procedure, we have to consider if the conjoint tendon is okay and still attached to the graft, and also the osteolysis of the graft, because we know that is a problem. In the series we have now, more than or approximately half of the patients have some kind of osteolysis in the graft after 1 year in CT. And we also have to consider if the graft is large enough for a new fixation. There might be a small fracture in it, and in addition to the bone resorption. So sometimes the graft might be much smaller than it was the first time, but maybe we can still use it if we do a new fixation and add another soft tissue procedure, for example a remplissage to the new fixation. And of course, if the reason for the failed Latarjet is the poorly positioned or avulsed graft, then the reposition and refixation is always a valid option. This is another of my patients. He also had a previous Bankart. Many of our Latarjet patients are revisions of previous Bankarts. So I wasn't totally happy when I saw this CT scan, because I thought I placed the graft a little bit low and that maybe the graft is a little bit small, but it was good enough to accept, so I did not do a revision early on. And when he came back after 3 months, he was happy and stable, and seemed to went well. Unfortunately, he went to a party and he had a little bit much to drink, so he was not really able to tell me what happened, but he was doing push-ups, and the day after he woke up with a lot of pain, and I saw him after a few weeks because he just waited and hoped it was going to be okay again, and then he felt also instability. So the graft was loose from the glenoid, and you can see it was a little bit small already after the first day after operation, and now I doubt that I would be able to do a new fixation and make him stable with the same graft. And I also have to consider when doing a reoperation, we know that the recurrence instability after the primary Latarjet is pretty low compared to Bankart, but it's reported from 0 to 14%, and after doing revision surgery, it's even higher, as high as 18% in the literature. So what are our options? Well, maybe there are even more, like xenograft, but at least these three grafts are those who are mostly used on the market, and they all have advantages and disadvantages. So for the iliac crest, you can have a large graft, and we know that the reported outcomes are similar to Latarjet, so it's a suitable graft. It does not have any articular cartilage, and maybe the biggest disadvantage is the donor site morbidity. But it's an autograft, and we tend to think that that's a little bit better than the allograft. And then there's a mistake. It says, no, sorry, it's the distal clavicle autograft, as we heard Paul Hussmann was talking about. Yeah, there is a mistake. I'll do the other box as well. The boxes has switched place. I updated that, but it's still wrong. So, well, for the distal clavicle, it has a cartilage surface, and it's a local graft, so it's donor site morbidity, of course, but this is local one, so it's more acceptable for the patients. But the graft is smaller, and of course the patient might have some degree of AC joint osteoarthritis. And for the distal tibia allograft, not everybody have that available, but for those who can use the distal tibia allograft, it can be a large graft, and you can place it so it's congruent with the glenoid, and it also has a cartilage surface. However, the availability and possible osteolysis because of allograft might be a problem with the distal tibia allograft. So this is the guy we saw in the last slide. The coracoid was loose, and it was quite a small graft. The conjoined tendon seemed to be attached to the graft. However, we decided to move on with the iliac crest bone block. Oh, here it goes again. I'll try to move it on the other screen. There we go. Okay, so Ettore told us how easy it is with the bone block procedure, and it probably is when you do it many times. So I'll just show how it goes when I try to do it, because I tangle the sutures, of course. But I saw it because I have marked the sutures, so I was able to pull the graft out again. So this video just to remind everybody that if you want to try this procedure, you have to be very careful with your sutures and pull them one by one bundle out, so you know exactly that there are no tangling and you know the direction of your graft. These slides are not, no. Okay, here it comes again, the right way. And when you do it the right way, it's much more easy. And we were able to get it in position. A little bit slow here, yes. So here's the graft in position, looking from posterior, testing the stability, and I also learned like Mikael said earlier today that we do the tension to at least 3 times 100 Newton now. In the beginning we did just 1, and I found that some of the grafts were loose then. So here is the same graft looking from anterolateral. The postoperative CT scan after, and he has been now for follow-ups, and he is now stable without pain. So yes, you can have a good result also after the failed Latarjet and reoperation. But this is, like I said, experience from case to case. There's not much literature out there. I found this systematic review from 21, including just 11 studies, and most of them are case series. There are 5 retrospective small series. So this, the mean average follow-up was 52 months, and their conclusion on these 250 patients was that Inhibinet and arthroscopic capsuloplasty was the most popular revision procedures, and those were also safe and yield reasonable clinical outcomes. And there's also a publication from, it's not moving again, also a publication from effort, and this group is trying to guide us what to do from case to case, led by Emilio Calvo. And they published a flowchart. After failed Latarjet, always do a CT scan. If the graft is non-suitable, then you go to a free bone graft. If the graft is suitable, you can try to refixate it, or you can do additionally soft tissue procedures. Sorry. So I think that was about it. The summary. Find out why they failed, and surgical revision of these cases is very challenging. So you can do open or arthroscopic according to your experience, and you can also choose bone graft according to your availability. But you should prepare well for these challenging cases. Thank you.